Welcome to another episode of Park Avenue Plastic Surgery Class, the podcast where we explore controversies and breaking issues in plastic surgery. I'm your co-host, Doreen Wu. I'm excited to be here with Dr. Lawrence Bass, Park Avenue plastic surgeon, educator, and technology innovator, as well as our special guest, plastic surgeon Dr. Steve Cohen from San Diego, California. The title of today's episode is The Rise of Regenerative Medicine, Breathing New Life into Aesthetic Care. Dr. Bass, regenerative medicine is creating a lot of buzz in the media these days. What exactly is regenerative medicine, and will this become the future of cosmetic medicine and plastic surgery?
Well, regenerative medicine is basically a branch of medicine or medical research and investigation that's designed to get the body to regenerate or restore itself to normal structure and function when there's a disease or an aging change or some other problem. And in broad strokes, this falls into a few different categories. So there are molecular materials that can help with tissue regeneration. There are cellular materials, and then there's tissue-based regenerative medicine using either natural or biomaterials or artificial materials that are designed to help the body regenerate. So there's a whole range of things that are being used to help enable tissue regeneration in the body, restoration of normal function in a cell or an organ or a tissue. In a lot of ways, plastic surgery is really the right field for this because I always said plastic surgery, we're the biomaterial specialists of the body, and the entire history of plastic surgery has been using a biomaterial that's borrowed from somewhere in the body, a skin graft, a bone graft, a fat graft, or a nerve graft, tendon graft, to rebuild or restore surgically some kind of body function. So this is really something that plastic surgery has done since time was. And in the last 50 or 70 years, research into wound healing and then tissue regeneration, growth factors, and all kinds of cellular biology that relates to the issues of interest to plastic surgeons has been an increasing part of plastic surgery on an academic level. So that's really why plastic surgery is involved. Let me turn to our guest today, Dr. Steve Cohen. He is a very talented and very experienced plastic surgeon from San Diego, California. We've been friends for a number of years and have lectured together at a variety of meetings. And he is a true expert on what's going on in regenerative medicine in plastic surgery. He teaches a whole range of instructional courses on techniques to use this kind of approach to best advantage. So, Steve, welcome, and we're delighted to have you with us today.
Thank you, Larry. Nice to be here.
So tell me, what are some of the leading examples of regenerative medicine in healthcare generally and in reconstructive plastic surgery?
So I think, there are two main fields right now. We have within plastic surgery, and really we're a good example of both of these. We have regenerative techniques that are designed to reconstruct injured tissue, congenitally absent tissue, or deformed tissue. And then we have techniques that are designed to be more anti-aging or replacement of losses that occur through the aging process. And I think that both have become much more mainstream than ever. And I do think, as you had alluded to, Larry, this is going to be a breakout area that as industry becomes involved and realizes to what extent this is going to be effective, this will start to really pick up and become even more mainstream. And so right now, at least most of the focus within our specialty are directed to things like rebuilding breast tissue, rebuilding facial tissue, for reconstructive needs, healing wounds that are difficult to heal, improving blood supply in circumstances where blood supply has compromised the ability to heal, and in also performing these techniques to modulate inflammatory conditions, to reduce them. So there are probably many areas in plastic surgery and dermatology that heretofore have not been treated but are good targets. For instance, psoriasis and many autoimmune diseases that lead to wasting like scleroderma. These are ideal conditions to be treated with, regenerative approaches.
Well, that's a fantastic summary of the playing field in plastic surgery. Now, could you share with us some of the potential applications in aesthetic medicine and anti-aging?
The exciting part about being around today, and things I'm sure that Doreen will find out as her future, begins to unfold, is that, with our understanding of the human genome, we know at birth in many situations where we're headed. Even without the genome, we can look at our parents or our grandparents and our family and get a glimpse into our future. And if one starts to think about aesthetics as more of a moving picture versus just one moment in time that a patient walks into our office, but a life cycle of aging, then we can start to devise regenerative approaches that begin to really, really make sense and resonate not only with our clients and our patients, but our colleagues, because again, many people are resistant to change and they get comfortable treating things in certain ways, using fillers and using Botox, etc. And they poo-poo the events that are lying in front of their nose, which I think are becoming, to me, much more clear than ever as to what the potential is. So it's a long statement, but I think if one starts to think about why people come into a cosmetic surgery office, they really come in for only a handful of reasons. So let's take facial aging as an example, because that's kind of the area I'm most interested in. People come in with really three major things we treat. We treat sun damage. We treat facial volume loss, which is not like air, it's loss of specific tissues, from thinning of the skin to loss of the bone or genetically deficient bone to loss of the, if you will, functional matrix of the face, the fat compartments and the soft tissues. And those along with laxity are the three things we treat. Every device is designed for them. Every surgery is designed to treat these things. And so educating ourselves and our patients about what they're able to accomplish with that in mind is critical. These are now superimposed on our genetics. So, you're born with a weak chin. Yes, you're probably going to develop laxity in the neck more rapidly than somebody else. Or, if you're born in a family that is prone to melasma, instead of laughing at, being in Hong Kong and seeing a mom and their little daughter with parasols and hats, instead of laughing at that, we can realize that this is an attempt at epigenetic modification. And by that, I mean, these folks know that sun will create hyperpigmentation. So the more they protect their children from day one, the less of that kind of sun damage and irregularity and injury to their skin tissue they're going to see. So as we start to turn the light on these matters, we begin to look at things more dynamically. So, for instance, in my practice, it comes up frequently, what's the difference with fillers versus, for instance, fat grafting? And it's I think we've explained this in some ways correctly and in other ways incorrectly, because we tell people, well, fat is like a natural filler, and then we say, yeah, but there's more variability, it disappears more rapidly in some people, it doesn't work in others, instead of going, when we're using your materials such as fat, if you are older, you have more cells that are already senescent. you can't expect that that's going to perform the same way as youthful tissue. That's number one. Two, we can say, look, based on genetics, they're rapid agers and they're slow agers. You go to a high school reunion, you look at some friends, you go, my God, I can't believe how great they look. They must have had surgery. You look at other people, you go, my God, I hope I'm not that old. We're the same age. Because in many ways, and this has been the difficulty with these studies, is the genetic variation of how our tissues respond to environmental injuries are different for all of us. So now that we're using our own tissue, we have to take that into account, that it's not necessarily a failure of a procedure in regenerative medicine. It's a combination of using cells that may already be in states that are aged and working with people whose genetics may not be as ideal as someone else. And in addition, using our natural materials that, of course, are never synthetics and programmed to disappear within a certain amount of time. Once we have that in mind, we can actually start to look at patients more like a moving picture. It's kind of like Leonardo da Vinci. He was the first person to start drawing an arm in different motions, because when we pictured a hand or an arm and it was in one motion or one position by an artist, that was a hand or an arm. What Leonardo said was, no, the function is as important as the appearance. So when we are thinking about hands and arms, we need to be thinking about each step of motion and function. And as we start to think about aging, we start to think about the gradual decline. And you come to realize that when a patient comes in for more than one filler, that reason is not because they see hollowing and we go, oh, yeah, I see the hollowing. It's because they're losing specific tissue in superficial and deep fat compartments. And we can actually put that same tissue back in. So just as we reconstruct, things with like tissue, we use a skin graft to repair a skin, a skin injury. We use, you know, fat tissue to rebuild the breast. Now we're starting to think more on a smaller histologic and morphologic basis, and we start to use those materials to actually replace what we're losing. And again, I'm sorry to be so long-winded, but if you think of nuclear decay as kind of a comparison, it's the amount of material you start with and the amount of material you end with and how rapidly you get there. So the rate of nuclear decay is based on a lot of factors. The rate of our tissue decay is based on many factors. But by definition, if you replace what has been lost, that curve of decay changes. Now you have more material, you have a slower rate of decay. So, just like we're beginning to realize that diet, exercise, and other kinds of epigenetic modifications are going to keep us alive longer, it's no different for facial tissues. This is why regenerative medicine has to be looked at in a dynamic way, much like integrative medicine, because that's really what it is. We're now not only aesthetically improving our patients, but we're marrying this by altering the physiology of aging and slowing that process, and in some cases reversing it.
Well, that's really beautifully said, and something that I tell my patients, and I've said on this podcast multiple times, is that aesthetic plastic surgery is a process, it's not an event.
I think that's a good point.
What you started by saying that people don't come in and get one hit and it's all over. But a lot of the synthetic materials, injectable fillers, things that we bring in with energy devices have a nearly monolithic approach to what they do to modulate the equation, where regenerative techniques are multidimensional and much more dynamic. As we really unlock some of the secrets to how these things work, we're going to be able to push them in many directions and maybe several directions at once in terms of restoring normal physiology and normal anatomy, normal morphology. So I've paraphrased what you said, in a much more simple-minded way. But I agree completely. That's really the essence of what's going on in this field.
Very exciting because it begins to help you focus on so many different things. It's the same with sports injuries. These are acquired injuries. Early on, we treat a knee injury that's, ongoing, or early arthritis with steroid injections. They get better symptom-wise, but the steroid actually decreases the cartilage interface. However, when we use regenerative techniques, even though we might only be getting a 20% improvement, that's 20% more than zero. That's an enormous improvement relative to our present therapy that has no improvement, and if anything, reduces symptoms while accelerating the disease process that they're trying to treat. So that's why I think our thinking has to change, and we have to become much more open-minded about using our own tissue repair mechanisms, because we're a complex organism. My God, we find amazing things like digoxin in a plant. We're bound to find more complicated things in a human being that will help us survive longer and live better.
Continuing our discussion of anti-aging and turning back the clock, what is here and now in regenerative medicine?
Okay, good point. So we just published an article in the Aesthetic Surgery Journal a couple months ago showing progressive improvement in facial volume following a anatomic and regenerative fat grafting procedure. And what that means is, when we look at a patient and we diagnose all areas of deep fat loss, superficial fat loss, skin thinning, and bone deficiency, and we treat them by replacing the anatomic losses with a structural fat graft, and we add the cells from fat to the skin and tissues, and we send them home with a biocream of their cells that they apply topically. And we follow those patients for 2 years, and we look at the midface as kind of a glimpse into what's happening with volume. When we do isolated fat grafting in somebody under age 55 with that approach, so we're using theoretically younger cells, less cells that are already senescent or aged, we see at a month a 60% improvement in facial volume. At 6 to 9 months, we see only about a 25% improvement. And at 19 months, we see almost an 80% improvement. Because what's happening is you're putting fat in, most of the fat cells are dying. The stem cells in fat survive at lower oxygen tensions, and they begin to turn into fat cells. So you see this kind of, bimodal kind of curve that at the end actually shows progressive improvement in facial volume. This is irregardless of weight gain. So when you do statistical analysis on these patients to say, was weight a factor, there was no gain in any of these patients. I think there was a 0.3% or a 0.3% loss, but no gain. Two, when you look at the amount of fat that you put in, it has nothing to do with the amount. So neither one of these affected the statistics of that curve when you were under 55. However, if you had that same procedure and you were older than 55, gradually the facial volume trailed off to 30% residual at 19 months later, which is consistent with most of the studies in our literature. Now, that's still a 30% gain at 2 years, but it's an indication that more youthful tissue is important to be using, and that is the first study that's ever shown an nearly 80% volume effect or volume improvement 2 years after a treatment. So we're not talking about stability, we're actually talking about improvement. So I think that, in my opinion, represents a very important article, because it contradicts every article about fat grafting. So instead of being not just the surgical artist where I put it where it looks pretty, now we're the surgical anatomist, and we're also regenerative medicine experts. So we know that when we microneedle these cells into the skin actually becomes healthier. The pigment actually becomes reduced. The age changes and the sun damage changes become reversed in elastin and collagen fibers. And there are enough very good studies that now show this very definitively. So to me, we're still talking about things that are already either passe or very poorly studied.
And that's really the point. I read that article with a great deal of interest, and the challenge is in meticulously assessing the patients, because so many of the articles, the metrics by which you're measuring outcome are so crude or so haphazardly applied that the data is only a very rough indication. And so your much more careful analysis of the patients is really what led you unlock that nuance of the biology, younger fat graft patients versus older, and rather than putting everybody into a giant grab bag and sort of losing the granularity of the data.
Yeah, I think as we have more of these, and again, Larry, as you know, we're both practicing plastic surgeons, so we know that data doesn't convince always our colleagues because people form habits, and I always was taught you form a habit and you learn to break it because you find something that's better, and other people are taught I want to imitate my mentor and what they did and be as good as them, versus we want to make things even better and stand on the shoulders of our mentors and move the field beyond what they've been able to accomplish.
And I agree with you completely. I think that's the point, that to move things forward, you have to unlock the principle and then learn how to amplify it. And so many people look at something at a rudimentary stage and say, well, there's an effect there, but that's just not enough. And they abandon it rather than saying, how can we harness it? How can we really control it? And how can we magnify the effect to, to an extent that is clinically relevant? uh, a 20% improvement. I mean, you age over 30 years, 50 years, and if you can undo 20% in a single step, that is a massive change. So it is clinically significant.
And there's going to be some things coming down the pike, Larry, that are going to be so exciting and potentially, relatively straightforward and simple kinds of things, I mean, for instance, you may be familiar with a company, Elysium Health, um, but they make a product called Basis, which is a NAD product, so it basically, it leads to cell repair. They have 5 or 6 Nobel laureates on their board. This is an MIT founded company. You know, these people are not stupid, but you need to take this medication and or vitamin or whatever you want to call the over-counter use on a regular basis if you want to succeed. Just like, you want more muscles, you got to go to the gym. Nobody's going to just hand them to you. At least not in my family.
No, that's true. There's always going to be some steps that have to be taken, and getting those steps as efficient and focused as possible is always the trick. So as we look at this, let's talk for a second about exosomes and what role they currently play or what role they might play going forward.
Well, it's not a well understood area by most plastic surgeons, and I have to say, I still feel like I'm at the tip of the iceberg myself, but I think, exosomes may turn out to be the active ingredient in the fat graft that leads to regeneration. So what exosomes are they're cell-to-cell messengers. They're responsible for what we call these hormonal effects that cells can do, or paracrine effects. Sorry to be medical, but that's what they do. Um, so they communicate to other cells, and what they do is they repair, they reduce inflammation, they probably survey for cancer and cells that are degenerating. They're able to repair. But what's really fascinating about exosomes, as in terms of anti-aging and in our deal, are one, something called parabiosis. So parabiosis was a study that was done and published in Nature many years ago. And what they did was they joined the circulations of an old mouse to a new mouse, a young mouse. And what they found is over a period of time, after they sacrificed the mice, that the older mouse's organs, the heart, the brain, the lungs, the liver, all got younger. Why did they get younger? These are not vampires sucking on somebody's blood. These are mice, and the younger mouses had something in their blood that circulated and caused repair and regeneration, and those were exosomes. The study was duplicated by taking the blood from that young mouse and injecting it into the tail of the older mouse, and they saw some very similar findings. Well, when you hear about these things, we're steps away from exosomes being used as anti-aging agents. Now, where do you get exosomes? Well, you get them from humans, and this is where the FDA and the regulatory issues become tricky because to get exosomes from humans requires you to culture stem cells. In culturing stem cells, they go through many iterations, they age themselves, and we don't always know what's in the packet that we get from the exosomes in these human stem cells. Now, that said, animal exosomes are close to ours. Obviously monkeys are the closest, but things like bovine kinds of exosomes. So exosomes that you can get from the cord blood of a calf without even having to sacrifice the calf, those exosomes can actually be used in a variety of forms. And it's conceivable that they can be turned into a pill form that we begin to take on a regular basis. But these are things that are very exciting about exosomes systemically and for anti-aging. For aesthetics, topical exosomes are also very exciting, but again, they face the same problem. There is no FDA labeling. Those of us that are using these exosomes are using them really in a way that is not considered to be FDA approved. So we may be practicing medicine feeling they're very safe, and likely they are. But as we start to move towards some of the products that can be in the US and on shelves, even in places like Nordstrom's, that are significantly more powerful than the most powerful agent in any cosmetic, which is retinol, we're going to start to see exosomes really blast off. And they may blast off not so in medical treatment, they're blasting off because that's what our vaccines are made from. But in cosmetic treatment, they may blast off on the shelves of Nordstrom's before they even enter the doctor's office. So
Yeah, they are exciting. And one of the ways I think about this, and you can say whether you think this is a worthwhile form of thinking, but for the listeners, when we take something like a growth factor, well, that's a molecule that the body uses to signal cells to increase inflammation or decrease, or increase collagen synthesis or decrease. And when we dribble that onto a problem wound that's being slow to heal, the body's getting some of that message that it uses itself to tell itself how to heal a wound, and it may help with a problem wound. But the dosing and presentation of that growth factor really doesn't resemble very closely how the body signals itself. And exosomes transferring message cell to cell comes closer to resembling that kind of messaging, although we still have a lot to understand about the pharmacodynamics and dosing of how we would ideally use exosomes. They're probably going to resemble more closely. And that's the way I think about it.
I think that's a good way to think about it. I think that's actually very valid.
On this podcast, we like to talk about recent developments and new research directions. And Dr. Cohen, you already briefly touched upon this earlier with NAD, but I'm wondering what else is in the works that we can expect in the next 5 to 10 years?
Well, I think, understanding more about the effect of intermittent starvation will be interesting to learn more about. There are many medications that are being tested on humans to see if they do have anti-aging effects. These are going to be systemic effects. Early diagnosis is going to be critical. Again, all of these things play into the role of, in my opinion, the discovery of the human genome. We know what's broken at birth. So I think some of the way medicine will change, it'll become a much more proactive and preventative kind of approach versus wait till you get a disease and then come in and we hope we can cure you with a big operation. It's going to be, look, you're going to get this disease. We need to do everything possible to modify it. Every one of your, male relatives died at age 38 of a heart attack. Well, you're 2 years old. What do you think is going to happen to you? Likely, unless you got the luck of the draw, you're going to have the same genes. So why wouldn't we start to be thinking about putting those patients, even as children, on things like Lipitor or certainly diet modification and things like that? As we become more intelligent, if we're able to change our habits, then I think we're going to actually be able to apply so many of these different things to ourselves. Same thing with aesthetics. If we start, Doreen, at your age versus at my age, you have the opportunity to really slow down your aging process. Other people are, not able to do that quite as effectively or without the knife, etc. So I think that in aesthetics, we're going to see some amazing changes. The other thing I should mention about new things coming down the pike, we just finished a study. I think we've done now 50 patients. It hasn't been written up yet. It's been reported overseas, but women that are not able to get pregnant and go through, huge amounts of financial burdens to try to, create an embryo and then implant it, still have kind of high rates of failure. We've now done women where we've injected the ovaries with stromal vascular fraction, which is the cells in fat minus the fat cells. We've injected their endometrium with stromal vascular fraction, and we've been able to achieve 85 to 90% success rates in implantation in those patients now. So that's another example. There's so many different things. Genital rejuvenation, for vaginal rejuvenation, and for erectile dysfunction, hair loss, you know, sports medicine and wellness. These are all things that, in my opinion, if they're used properly, not like sensationally, but properly, all will make huge amounts of sense now to be doing.
Lastly, I want to wrap up our episode today by asking both of you for some key takeaways from our discussion of regenerative medicine. If Dr. Bass, you'd like to go first.
So I think you can hear from this discussion that we are really at the dawn of what regenerative medicine is going to be able to do for us and how central a role it's going to play, not only in aesthetic plastic surgery and aesthetic medicine, but in all fields of medicine. So this is the beginning, and as the capabilities expand, as careful study accelerates, which is happening now, we're just going to see this torrent of application kick in at some point that really transforms in a major way the entire way we approach clinical care of patients. And again, not just in aesthetic plastic surgery, but in medicine generally.
Yeah, I would echo what Dr. Bass just said, that we're at the beginning of a new era, and I've spent 20 years in this industry, and I've watched companies who've raised $600 million fail and go bankrupt because the expectations have not been understood. The studies are so difficult to carry out. There's not a single study that controls for the genetics of this. So, for instance, if you look at the methylation processes on a chromosome, which is a way of looking at the youthfulness of your cell, some people already are kind of too late, sorry, and other people are just right. If we can factor these things in and understand them, we'll have home run studies. But right now, we're still kind of going, this side we put fat in, this side we put fat with cells in, and we don't see a big difference. And that may not really be the right studies to be doing. So I think, just like bone marrow transplantation has no FDA approval, just like the heart-lung machine has no FDA approval, there's certain things in medicine that are going to happen irregardless of the FDA because they make too much sense. And using our own body parts and materials and recycling them and using them to our advantage makes so much sense to most people. And the safety is just, unparalleled because it's us now.
It's going to be a brave new world. Well, Dr. Cohen, I'd like to thank you for joining us. It's been a tremendous pleasure and very appreciative to have someone with your level of expertise in this field sharing perspectives on what's happening.
Thank you, Larry. It's been a pleasure.
I'll echo Dr. Bass and express my thanks to Dr. Cohen for taking the time to share your insight and expertise with us. And thank you to our listeners for joining us today to hear about the growing and exciting potential of regenerative medicine. I hope you found this episode as fascinating and informative as I did. If you think of other exciting developments or trends in plastic surgery that you would like us to discuss in an upcoming episode, please reach out via email or Instagram. We'll see you next time. This is Doreen Wu, thanking you for joining Dr. Bass, Dr. Cohen, and me for this discussion of the role of regenerative medicine in the future of plastic surgery and anti-aging. Be sure to tune in next time, and don't forget to subscribe to our podcast to stay up to date with all of the exciting content that is coming your way.
Thank you for joining us in this episode of the Park Avenue Plastic Surgery Class podcast with Dr. Lawrence Bass, Park Avenue plastic surgeon, educator, and technology innovator. The commentary in this podcast represents opinion. This podcast does not present medical advice, but rather general information about plastic surgery that does not necessarily relate to the specific conditions of any individual patient. No doctor-patient relationship is established by listening to or participating in this podcast. Consult your physician to advise you about your individual healthcare. If you enjoyed this episode, please share it with your friends, and be sure to subscribe to our podcast on Apple Podcasts, Google, Spotify, Stitcher, or wherever you listen to podcasts.